On-the-scene video coverage of AHA 2012 is supported by Pradaxa.
Thank you, Dr. Antman. Good morning, ladies and gentlemen. It's a privilege for me to comment on this important and interesting work. Here are some disclosures published on our website at the University of Alberta Vigor Centre. To suggest that this study is steeped in history or controversy would be an underestimate, and as depicted here from a report published in 2002, on the one hand, it's been suggested that chelation therapy is valuable, effective, and safe, and the other pole of opinion suggests that it's likely unsafe, certainly ineffective, and should be abandoned. So there has been no lack of controversy on this subject. We owe Dr. Lamas and his colleagues a debt of gratitude for their willingness to undertake this important subject and their determination to see it through and bring it to us today. This slide, which was meant to be animated, will be difficult for you to read. In fact, I'm having trouble reading the yellow text, but the fact of the matter is that it's been increasing in use in the United States to over 100,000 per year at last estimates. It's expensive and out of pocket, approximately $5,000 for each patient to see a course of therapy. And the trial has also recognized that it imposes a significant burden on patients and has the potential for serious side effects. The trial itself has been challenging in operation, with an original 36-month period of enrollment that has gone 7+ years. And Dr. Lamas provided a progress report in 2006, at which point 900 patients had been enrolled at 100 U.S. sites. In September 2008, the trial was temporarily suspended, and an oversight committee convened to explore issues around consent and the conduct of the study, and subsequently those were addressed, and the trial was then restarted in June of 2009. You've heard that the number of patients enrolled was 1,708 as opposed to the original sample size of over 2,300, and it is striking that there was difficulty in enrollment despite the increase in the use of this therapy. The primary composite was death, myocardial infarction, stroke, coronary revascularization, and hospitalization for angina. And I'd like in this slide to remind you that the primary event composite was indeed positive. It consisted of 483 events, and there was an intergroup difference of 39. I'm now showing you what Dr. Lamas has shown you, but in a different format. This shows you the not only the point estimates, but the confidence limits, with the vertical line then suggesting unity or the inability to discriminate one from the other. And as you can see, and as he pointed out, the primary endpoint is of marginal significance with about an 18% relative risk as opposed to the original 25% projected. And that's in large part, as you can move your eyes down to the yellow highlight on coronary revascularization, an important but subjective undertaking, that over half of the events, as you can see, the 130, 157 numbers, as opposed to the top numbers of 222 and 261, over half of the events, in fact, were accounted for by this undertaking. I want to come back to the issue of diabetes that he has shown you and highlight on the left the primary composite and on the right the patients with diabetics, which constituted almost a third of the overall sample, and indeed the large majority of the intergroup difference. I told you that there were 39 events that were different. 35 of those occurred in the diabetic population, an interesting observation of potential biologic plausibility. We have not yet, and I know Dr. Lamas and his colleagues intend to publish this important work, and we look forward to being able to review it in the peer-reviewed literature. So what we're dealing with today is obviously a snapshot of an extraordinary amount of work. And what I would like to know that I do not know today is what the power is to exclude chance, given the sample size the reduction in the estimated risk ratio and the p-value of marginal significance and its ability to accommodate for the frequent interim looks as he's articulated. I'd like to know whether there's an interaction between the EDTA component of the therapy and high-dose vitamins, because this is a complex therapy. And indeed, the impact of the very long window of enrollment and the interruption of the trial relative to the length of follow-up, the adequacy of follow-up, compliance, retention, and crossover deserves our attention. And indeed, so too does the comparability and the adequacy of background therapy, not only at the baseline, but over the long period of follow-up in terms of its comparability between the groups. Finally, as published on clinicaltrials.gov, the primary endpoint is different than the one that you've seen today. Coronary revascularization has been added, and heart failure due to hospitalization, heart failure-related hospitalization has been deleted. And we would like to know more about the safety relative to heart failure and renal side effects. The mechanisms of benefit, if they exist, and the logic of the subgroups, especially anterior MI, deserve our consideration. And we will hear more about the impact on quality of life and functional status during this meeting. So my reflections in conclusion, Mr. Chairman, are that this is a diverse, multi-component intervention that we've been presented. There is an absence of a clear biologic rationale. There are several operational methodologic issues that deserve our attention. There's a high proportion of diabetics who dominate the treatment effect. Coronary revascularization is the principal driver, and I would comment that it's collinear with the angina hospitalization in the composite. And I would perceive that these results are hypothesis generating, not practice changing. Thank you.